Good afternoon, everyone. Thank you for joining our QTECH meeting for August. My name is Stephanie Martinez. We will begin shortly. Just give us a few more minutes. We've got some folks still logging on. Thanks. Hi, everyone. Welcome. Thank you for joining QTECH. This is our August monthly meeting. My name is Stephanie Martinez. We're going to give it about a minute or two more before we get started. So hang tight. Thanks. All right. Thank you, everyone, for joining us for QTECH today. Um, it is our August meeting. My name is Stephanie Martinez. I'm going to kick us off. Normally, Meredith Marsh, our Quality Improvement Officer, usually kicks us off, but I will be in her place today. So we welcome back all our participating health centers. We've got 30 of you all on, and it's great to see our list growing. We get more and more attendees every month, so we're very excited about that. We do have a packed agenda today, so I'm going to go very quickly through this so that we can get started. First, we've got welcome and introductions by me, yours truly. I will also be going over our Class Art Collaborative Initiative. This is very important. We're very excited to roll out this information to you all. It is coming now in September. And next, we've got telehealth work group updates for you all, and that will be done by Jillian. Then we're going to do some UDS updates with Harut. Then we've got our health center spotlight, which I know all our health centers like to hear from what our health centers are doing. So we've got Dr. Sal and Dr. Gates presenting for Providence Community Health. And then we've got our other health center spotlight with Family Health Center of Southwest Florida with Robin Pagione presenting. All right. All right, so thank you for logging on today. You know, HCN has become members with the Class Art Collaborative, which is a provider-driven effort to help organizations find real solutions to improving the EHR experience across the industry as a whole. The initiative was actually born of QTECH. As many of you know, QTECH is our HRSA HCCN grant, and it is the main source of funding HRSA provides us as a network. And every 3 years, those goals and objectives change. Through QTECH committee, and here every month, we strive to bring relevant topics and discussions around the goals of the grant that HRSA has asked us to concentrate on with the health centers. That being said, one of our grant goals for this current 3-year cycle, as many of you know, is to enhance the patient and provider experience. Under this goal, one of our objectives is provider burden. The goal here is to help our health centers improve health IT usability to minimize provider burden and staff burden using the EMR. So to that end, what is our health centers EHR experience? HCN, along with other HCCNs and PCAs, have partnered together to ask some important questions like the ones you see listed here on the slide. How satisfied is your staff with the EMR? It could be very informative to get a better understanding of the staff's concerns and needs around the EMR. This could help inform where and how the EMR experience can be improved at the health center level. And on the other side of that is what are other organizations thinking about the EMR, right? How do they feel about the same EMR that you're potentially on? Or for that matter, other EMRs. Your health center might be interested in knowing how other health centers feel about other EMRs. This survey will be inclusive of other EMRs, not just the basic EMR like Epic or Intergy or Athena. We are talking dental and behavioral health EMRs here as well. Um, you know, you've all heard of bringing back the joy in practice, provider burden. We understand that the EMR and the workflows around it play a role on the burden that the care teams feel. So, why joy in practice, right? So, we know physicians' burnout is associated with making mistakes, scoring lower on scales of measures of empathy, reduce patient satisfaction, and reduce patient adherence to treatment plans. So, ultimately, we want better patient outcomes. So if we want better patient outcomes, we want happier care teams, we want happier providers, right? So I wanted to provide you a framework of where this fits in our QTECH grant. We have 30 participating health centers right now in our grant. This 3-year cycle of the HRSA grant gives us 3 goals with about 2 to 3 objectives per goal. Under our first goal, we've got that enhanced patient and provider experience. This objective has a few goals. We want to provide our health centers with objective information on the health center's staff experience with the EMR. The data will also give us an opportunity to analyze the data and plan for training opportunities, assessing workflows, and things like that. We have information on where the EMR and have information on where the EMR needs the most improvement. Um, those areas that we could focus on and improve first, you know, that's what's important about this survey. So another thing to think about is, you know, there's could be potentially health centers that are highly satisfied with the EMR. What are those health centers doing differently from others that are not so satisfied with the EMR? If you could just bear with. I apologize. I do have children in the background, so I had to mute myself and get myself away. So I apologize for that. Can you all hear me all right?
Yes, perfectly.
Okay, thank you. Thanks. All right. All right, so back to the Class Art Collaborative. So we currently the Class Art Collaborative is using measurement data to improve the EHR experience through training, government governance, and culture. They have insights from over 100,000 clinician respondents. They're helping organizations, find solutions to that difficult challenge with the EMR. I have provided on this slide for you all, and you'll get it after the meeting the link so that you all can look at the Class Art Collaborative, but HCN is bringing it to all the health centers. So what has class learned so far um, with their research, with working with other providers and organizations and care teams? They found that successful organizations have a quality EHR. Successful organizations help clinicians master the EHR use. They help clinicians personalize the EHR to their needs. They create shared ownership and teamwork across the organization. The graphic that you're actually seeing here depicts organizations using the same EMR, their satisfaction or dissatisfaction for that matter with the EMR result vary. And those feelings aren't so much around the EMR and its functionality, but also it's the factors that affect how they use the EMR around them, the workflows, the culture, and things like that. The Class Arch Collaborative developed a framework, shall we say, for to guide organizations on their journey to improve this utilization with the EMR. There's three traits that they identified in this formula. And the first is that the users feel that the EMR meets their unique needs for which they use the EMR to do their daily work, whether that be primary care, behavioral health, or working with targeted patient populations. Next is a strong mastery of the EMR that they truly believe they know how to use the EMR to capture and effectively report valuable information for patient care in the EMR. And lastly is shared ownership, that the users feel that they have a voice in influencing the shape and evolution of the EMR and how the health center is using it. For example, those who sit on optimization work groups who help develop and pilot new forms in the EMR or even work with the vendor to make changes necessary in the EMR tend to be more satisfied with the EMR than those who are not. So just to recap of those three things that they've discovered are that the EMR meets their needs, that strong user mastery, and shared ownership. So at a high level, we're taking part in this EHR experience survey as part of a national community health center network collaborative. This slide here shows all the community health center networks that will be taking the survey at the same time. Together, the impact of this survey and the data is immense. By all of us taking part in this survey at the same time, we're going to be able to obtain information not only on how our health centers are doing, but also what other health centers in the community health space are experiencing with similar and different EHR brands. We're going to be joining Alliance Chicago, Breakwater Health Network, CHAN, Hawaii Primary Care Association, INCC or In Concert Care, and the Vermont Rural Health Alliance. So, how does this all work? We're going to have one survey. It's going to be distributed to all our participating health centers. It's going to take about 15 minutes to complete. The goal is for any and all users of the EMR to take this survey, provider and non-provider roles. We're going to get some data analysis at multiple levels. There's going to be opportunity with consultation from class based on the survey results. Your health center will have objective data to truly understand your organization's EHR experience, understand satisfaction, and obtain detailed information on where and how the EHR experience needs to be improved at your health center. So impact. I wanted to talk a little bit about the impact. Class has had a lot of experience working with academic institutions, major hospital systems, private practices, but now there's an opportunity for the voice of the FQHCs to be heard. So what we're talking about is 33 states, 148 FQHCs, over 4,000 providers potentially, and over 20 EHR brands, including dental, behavioral health, aside from the primary EMR that we use. So what's the ask? So the roadshow started from the 17th through now through the beginning of September. This is part of my roadshow where I'm presenting at every venue possible. I'm sharing it in all our work groups. I've presented it with our CMO meeting yesterday. Our C-suite will be sharing with your C-suite detailed emails and information coming about this. Then we will, your CMOs and medical directors will also get some emails from Dr. Long, our Chief Clinical Officer, about this. The survey opens September 14th and it closes on October 23rd. All networks will be taking it at the same time. We'll be pushing out some emails, so more to come on this. I don't know if anybody has any questions, but that's pretty much it for me. Diana, do you see any questions in the chat?
There are no questions at this time.
All right, perfect. Well, more to come. We're very excited about this. With that said, I am going to pass it off to Jillian. Jillian is our clinical informatics specialist here at HCN. She's going to be providing some telehealth updates. Jillian, are you with us?
I am. Thank you, Stephanie. Hi, everybody. My name is Jillian Javed. I am, like Stephanie said, a clinical informatics specialist here at HCN. I work with a great team, the system optimization team. I have been with the organization for over 3 years now. Prior to that, I spent about 4 years as a training manager at one of our FQHCs within the network. I am a nurse by training, and I'm happy to be here today to talk a little bit about the work that is being done through one of our amazing work groups here at HCN in the network, our telehealth and optimization work group. So next slide. So the first thing we're going to talk about was an ask from the work group on possibly creating some sort of an easy way for a provider to be able to document in their encounter notes when they're in the middle of a telehealth visit and for whatever technical reason, the call has to be converted over to an audio only call. So we'll talk about what those options look like and how we built those and the wording that we're using. We're also going to talk about a few different documents that have been created for these work groups. The first one being a pre-visit telehealth checklist. And then we're also creating documents, patient and clinic facing etiquette documents. So some tips and tricks on things to think about when you're holding a telehealth visit for not only the provider and the clinical staff, but also the patients. There's also another document in here that we'll talk quickly about, and that's some troubleshooting and setup tips and tricks that you can think about or should think about every day before you get started, and then things that you could use that could come in handy if you're having any technical difficulties during your telehealth visits. And then we are going to open it up for any feedback. We would love to hear from everyone on some of the methods that you are currently using to collect patient data in this new telehealth space. So how are you getting those copies of the patient ID? How are you getting the consent forms, the registration packets, anything that you used to require a hard copy or a signature of? How are you currently getting that into your centers for those new patients or those patients that need their annual updates? So we can go ahead and go to the next slide. All right, so for those instances when you're in the middle of your telehealth call and everything's going right, and then all of a sudden, for whatever reason, you start experiencing those difficulties and you have to convert over to an audio only or basically a telephone call. How can a provider quickly and easily document that without having to hand type that? So we came out for our network, 2 different options. The first one is super quick and easy. We have a lot of forms that our providers use, to go through their visits, simple clicks that they can use grouped together so that they know everything that they need is kind of in one section. So we added a verbiage for a new checkbox for that. So previously you had either a by phone or a by live video and audio choice, and now there is a third option. And I will let you go down to the bottom of the screen, and that's the way it would actually read in the encounter notes. So under that reason for visit, and the verbiage states, this telehealth visit was initiated as a live video and audio call, but due to technical difficulties was completed using audio phone only. Prior to converting to audio only, the provider attempted to resolve the technical issues by checking all equipment, internet connections, and closing all unnecessary programs. So those are just a few quick and easy things that a provider could do to try and resolve some of these issues. Obviously, there's going to be more, and then depending on your software specifically, you might be able to get a little more detailed, to tailor it to your specific needs. But this is just a nice general statement to let the documentation show that you did try to make attempts to rectify the situation before converting it over to an audio only. Next slide. So because we know that providers document in slightly different ways, we also added a second option. So not only are they going to have that click button in the form, they also have the ability to use a shared text or a personal text. The language is exactly the same. It just allows them just a slightly different route to be able to add that same verbiage to their encounter note. So it gives some flexibility for what is easiest for that provider. Next slide. So this is one of the documents that we are creating. This is the setup and troubleshooting kind of quick tips to look at. And really this started out as, hey, we wanted a quick troubleshooting guide. What are some things that they can do in the middle of this situation to help rectify the situation? And it really turned into a setup and troubleshooting, because a lot of these tips are things that you should be doing every day or every morning when you get into the office. You want to quickly do simple things, and they're so easy, but sometimes even now, a lot of us are on calls all day, every day, and we might have to fiddle with our headset to make sure it's connected, the audio is connected correctly, or some things like that. So even though we're used to it, we still need to make sure that we're kind of going back and reminding ourselves of what we can do. So simple things like testing out your webcam first thing in the morning, making sure your volume is turned on, is your microphone is connected. Do you have everything plugged in? Is everything fully charged, whatever device you happen to be using? If you have the opportunity or the ability to use a wired internet connection, you're always going to get better than Wi-Fi, so hard wiring if possible. Closing extra programs. I know I'm guilty of this as well. Sometimes when I'm working, I might have 5, 6, 7, 8 different pages open of things because I'm doing 5 different things at the same time. So making sure that you're only opening those programs that you're actively using or you need for that moment, and closing everything out. Make sure you're using the right browser. Everybody's using different software vendors for our telehealth calls. Make sure that you're finding out from your IT team or the vendor, hey, what is the best browser to use? And they'll be able to tell you, hey, ours performs the best on these 1, 2, or 3 different browsers. So make sure you know that and are using those specifically. Rebooting daily. Give yourself, if you want to do it at the end of the day or at the beginning of the day, give your computer or your phone a hard reboot. That way you're kind of refreshing, making sure everything's closed out and you're starting fresh. And then, of course, if all else fails, make sure you have your support team's information readily available. You don't want to be in the middle of a situation. It's already frustrating enough. The patient's upset. You're probably getting upset. You don't want to have to figure out how to contact your support team easily. So just make sure you have that, whether it's a sticky note on the side or a card pinned to your board, whatever it needs to be, just make sure you have that quickly available to use in case you need to. All right, we can go to the next slide. So 2 or 3 actually other documents that we are creating out of the work groups. The first one is a pre-telehealth visit checklist. So this is just a guide, some suggestions, some items to point out. So how can we structure these pre-visit items, and what needs to be done, and what timeline should we be doing these? So this document goes over pre-visit items for your clinical support staff. So going in 3 to 5 days before the visit and scrubbing the patient's charts. Hey, are all of these appointments that are scheduled for telehealth calls appropriate for telehealth? Or does there have to be some sort of physical touching or exam that needs to happen? If they are appropriate for telehealth, do they have any outstanding labs or x-rays or documentation that we're expecting to get in that we need to hold. So a lot of those same things that you're doing when the patient's coming in, you'll want to make sure that you're following those same kinds of structure. Front desk staff, the day or two before, are they reaching out to the patient? Are they talking about, hey, this is how the telehealth visit is going to flow now. It's a little bit different. Are they getting the information to them on how to, how that call is going to go, what they might need to launch? Are they getting those patient documents, anything that they need? Are they updating the demographics over the phone, if that's the way your organization has chosen to do it? And then so on and so forth. So the day of visit items is the clinical support staff calling the patient, 30 minutes ahead of time to get their vitals and do kind of that pre-visit work before the clinician actually gets to see them. So that's one document, and hopefully these documents and all this information will be out here in the next 2 weeks. And so the next documents are provider and patient-facing etiquette items. And these can include environmental considerations, communication tips, and even dress ideas. So while doing this, I actually learned quite a lot of items that I really didn't think about, before that. And I think most importantly was the dress one. So we think, okay, we know how we're supposed to dress. We go to work every day, and we understand what that's like. But things like making sure that you're not wearing really elaborate patterns, you're not wearing any neon or super bright colors, anything that's distracting. Is your jewelry not too flashy? You want to make sure that you're not drawing attention away from yourself during these calls. Do you have a brush right next to you when you're in the middle? Maybe you just had lunch and, you need to, do you take a quick look at yourself to make sure, hey, I didn't get anything on my shirt, I brushed my hair, I'm ready for this call. So making sure you have things right next to you that you can jump on and make those calls as super efficient as possible. So those are coming soon. All right. So this is the last one, and I'd love to hear anybody out there who would like to share. How are you currently collecting documentation for your new patients or even those annual updates? Those things that you used to require a scanned copy of an ID or their insurance card or guardianship paperwork or consents. How are you getting that information now during these telehealth visits?
All right, so I've unmuted the lines on our end. If you'd like to speak, you can unmute yourself. We do have a comment in the chat, Jill, from Caitlin in St. Louis. She says we're struggling on how to no-show patients during telehealth visits. We'd love suggestions on that.
Yeah, that's great. So, I think maybe we need to talk a little bit more, but to know exactly what you're looking for. But I mean, entering a reason code or some sort of into the system that can clearly identify this patient was a no-show for a specific reason is something. But again, that's up to the system and whether or not you're able to create those kind of customizations. But yeah, Caitlin, let's talk offline.
Yeah, I would appreciate
Reach out
that.
to you.
Yeah, I would appreciate that. We used to just change their status, but when we have the front desk doing the pre-visit calls, we changing their arrival, we're changing their status to info, and that is what generates the encounter. And so then if a patient like doesn't answer or isn't available for their telehealth appointment, no show them. And a lot of providers are keeping the encounter that's generated and just typing free text in there, the patient wasn't available. And so now, we just need to figure out like a way to get around that. So yeah, I would love to talk offline about that. But I'm also curious if anybody else is having similar issues.
Anybody experiencing those where they're kind of getting the patients set up and ready to go, and then at the time of the visit, they're unable to reach them? How are they handling closing those notes that have been opened or documenting that? Okay, well, if nothing, Caitlin, I'll definitely reach out to you today. And then anybody else, if there's any other questions or if anybody has any anything they want to share on how they're collecting that patient documentation, that would be great.
Well, sorry, go ahead.
No, go. I was going to read something off the chat. Go right ahead.
Oh, okay. Well, Family Care is implementing Pharesia right now. So right now, it's kind of hard to collect this information, but we are implementing Pharesia soon. So that will all be contactless and patient a couple days before the visit via text message and email. So we're really excited about that.
That's great. I've seen Pharesia. Very nice.
And this is Howard at Community Health at Pinellas. We're using GetWell Network to do a similar. We've had them for a while, and we are currently, when a telehealth appointment is scheduled, Energy sends a note to GetWell, and GetWell automatically sends an email to the patient with a link, and all of our forms are online in GetWell. Patient fills them out. All those forms automatically get pushed in as PDFs into the patient record in Intergy, including consents and everything.
Great.
This is Isabel from Treasure Coast Community Health.
Hi.
Hi. We what we did at first, we did some PDF fillable forms, and we were emailing that to the patient. And then after the fact, we did start using Health Assist. So now we're getting all of our consents through Health Assist.
Health Assist. Great.
I do have some comments in the chat. Veronica Luna says, how are you all completing labs that are in-house? And then she also put, like patient has a televisit but needs to come in for a lab. Do you put charges on the televisit encounter or having them drop charges on like a nurse visit encounter?
We currently just encounter that here at TCCH. So we have an order group for those in-house testing, and mostly for like BH stuff. It seems to be here, and it's a nurse visit, and they're dropping charges on that nurse visit.
Thank you for that. Very helpful.
You're welcome.
I hope that answered Veronica's question. Oh, Tara's asking who is it that's using GetWell again? I'm sorry. Jillian, who is it that's using GetWell?
It's Community Health Centers of Pinellas. Howard Rubin.
Oh, hi, Howard.
Hi.
So Pinellas.
Yes.
Pinellas is using it.
One of the things that we're trying at Pinellas also is what we call a fast track, so that if they're doing a telehealth visit, then they can have the patient come into a fast track appointment at one of our bigger centers, and they can do those in-house labs at that time. And they leave the providers leave that chart open for the rest of that day or so until the patient gets in.
Great.
Thank you for that. Dr. Bendel is also asking to the group if anyone has experience with the Well app. Does anyone have experience with the Well app? Seems not. All right, Jillian. Well, thank you very much, Jillian. I don't think we have anything else in the chat, unless if you wanted to share anything else.
Nope, that's it for me. Thank you for having me.
All right.
Comment about capturing some of these forms. Our IT department has been able to set up a single textable number, and the images show up in a shared drive, so that patients who want to send information to us can do it that way, and then we can either put it in a chart or have it printed out. I don't know if that's a useful solution for some of you.
So they kind of can take us
exactly how they did it, but I'm sure we could get a write-up of it for you at some point.
Very interesting. That's new. That's very interesting. I'd definitely like to know more about that.
We found a lot of our telephonic visits, there was a desire to have an image taken of something, perhaps a rash, and in the absence of a dedicated phone, it was getting difficult.
Thank you.
And just before we move on, I do see that Andrea Brandes had their hand raised. Did you want to speak?
Hi, it was actually me, Isabel, and I spoke already. Thank you.
Thank you. Thank you for that. Making clear those on the chat. All right. Well, we're going to move on. I'm going to pass it off to Harut. She's our quality research and policy administrator, and she's going to provide us several topics actually today on UDS. Harut, are you with us? Harut, can you hear us? Are you with us? Harut, can you hear us? Hello?
Yes, I can.
Oh, there we go. Sorry
Hello?
about that. I don't know what was going on. We can hear you.
Okay, it looked like I was muted on your end. So anyhow, I am here. So I'm going to talk to you today a little bit about various UDS-related topics. As you all know, that's kind of my favorite subject. So the first thing I want to do is kind of cover some things that we have a lot to celebrate about. So the national averages have now been posted on HRSA for 2019. And so this chart just shows you how they've changed over the past couple of years. There aren't a lot of major changes between 2018 and 2019. I think the biggest change that I saw was with dental sealants, where the national average has gone up about 4 percentage points. Pediatric weight assessment and the BMI screening and follow-up measures have gone up about 2 percentage points each. And then for hypertension, blood pressure control, and depression screening, the national average has also gone up by a little bit more than 1%. Diabetes poor control has improved by just less than 1%. So those are the main changes. And there are some that have dipped a little bit and some that have gone up a little bit, but not a lot of very big changes. So these are on the HRSA website. Along with this, of course, they've released all of the compliance for each center and also the quartile ranking for each of these measures for each center. And just to remind you, the quartile rankings do take into account certain characteristics of each center, such as the number of uninsured patients, homeless patients, etc. So what you're compared with is like centers. And so then you are placed in one of 4 quartiles, depending on whether you're in the top 25%, the second or the third, you're given a quartile ranking of 1, 2, 3, or 4. So I was very pleased. I did go on and look at the quartile rankings for all of our members, and for the most part, I think we did great. There's a lot of members with a lot of measures that are in the first quartile. So if you haven't done so, please go look at the HRSA website and look around and see how you did. So if you can go to the next slide. So here, what I'm doing is, let's get to the next slide.
Can you see my slide? It's not moving on your end?
No, I'm stuck. I'm stuck on the first one.
Okay, hold on. That's not good. Let me stop showing and then re-show.
Okay.
How about now?
Yep.
There we go. It was frozen. Sorry, Harut.
Okay. I'm not seeing it yet, so maybe mine is slow. Okay, there we go. All right, so this now is comparing the national average to the HCN network-wide average. So again, this is for all of the centers that we host, as well as centers who provide me with their UDS numbers. So if you don't provide me with your UDS numbers, you're not included in here. And I would continue to really encourage those of you who are part of our QTECH grant but are not giving us monthly QTECH numbers. It really helps when we can put everybody together. But this represents the bulk of you. And as you can see, both in 2018, the difference, and in 2019, we did a lot better than the national average in most of these clinical measures. Looking at HCN average network-wide for 2019 versus the national average, you will notice that we have exceeded the national average for all but 3 of these measures. And the ones that we didn't are the access to prenatal care, which is kind of very difficult to control, the low birth weight one, and the appropriate use of medication for asthma, which is going away this year, so we will not have to worry about that one again. The other thing that I wanted to point out is that if you'll notice, you'll see that the percent difference in HCN network-wide average versus national average has actually gone up for most of these measures. So looking at, for example, childhood immunization, last time we exceeded the national average by 7.62%. Now we're exceeding it by 12.37%. And if you look down the line, you'll see the same with cervical cancer has gone up, colorectal cancer has gone up a little bit, controlling high blood pressure has gone up. So, for most of them, we are seeing an increase in the percent difference by which we are beating the national average. So I just want to say, time to congratulate yourselves for a job well done. This is something that makes me very proud because I am constantly looking at your numbers and trying to figure out how can we make you better. So very happy, and I hope you are too. The next slide just kind of basically shows a graphic representation of the 2018 difference. The blue line is HCN average, and the orangish one is national average. And the next one shows the 2019. As you can see, for some of them, the difference becomes more pronounced. So really excellent job on that. Overall, next slide, we beat the national average for 12 out of the 15 measures. In 4 measures, we exceeded it by 1 to 5%. In 4 measures, we exceeded between 5.1 and 15%, and for 3 of them, we actually exceeded by greater than 15%. So again, I think it's time for us to stop and congratulate ourselves for a job well done. Unfortunately, we have to wait like 8 months to really see how we measure up to the rest of the nation, but excellent work on 2019. So now we're going to move forward, and I'm just going to talk a little bit about some of the things that are, there's a lot of concern now with COVID. A lot of our measures are going down, but there are some that I want to kind of focus on today, and those are the colon cancer screening, pediatric immunization, and the diabetes pro control measure. For the colon cancer screening, I'm actually going to be looking at a lot of material that we found in a recent NAC webinar. So a lot of what you see about that is going to come from that webinar. And then I would really like to hear what you guys are doing in-house. So, and then we have a couple of centers that are going to be talking about their practices around some of these measures. These are centers that we've identified that year to date are doing relatively well with these measures and haven't dropped as much as others, and in some cases are actually holding steady. So just overall, cancer screening in the time of COVID has really taken a plunge, as you can see from this graphic here, from mammograms, pap smears, colonoscopies, CT scans, PSA tests, everything has gone down. And this is just a kind of a snapshot from the week, one of the weeks ending, from the week ending April 10th, and it compares to February in the 2020. So it's just taken a huge dive after the COVID pandemic started. And of course, part of this is just, fear of going in, and part of it was, that these kind of tests were kind of put on hold. So moving on to look more closely at colon cancer screening, we have a couple of poll questions just to kind of see if you have a sense of where we are. So for the first question, what was the drop in colonoscopies and biopsies by mid-April 2020 compared to the same period in 2019? And your choices are 60%, 70%, 80%, or 90%. So just take a guess, and then we'll look at the answers after we do all of the poll questions.
The poll
We'll
has
give you a
been
couple of minutes
launched.
to.
We're at about
Okay.
27% voting, so we'd love for you all to vote. The poll is launched, and you can click on it right on your screen.
There's no grading on this one. Just take a chance. Take your guess. I think we actually saw the answer for this one earlier.
All right. We're at about 55% voted. Do you want me to close out, Harut?
Yeah, that's fine. All right. So most of you thought it was 70%. Actually, yeah, most of you thought it was 70%. That's interesting. I'm going to give you the answer after we finish all the polls. Okay, the next polling question. Can we get to question number 2? All right. So what is the estimate of missed or delayed diagnosis for colorectal cancer from early March through early June of 2020? So this is looking at the estimate of missed or delayed diagnosis for colorectal cancer.
We're at about 35% have voted. We'll give it a few more seconds. Okay, it looks like the voting has slowed down somewhat. I'm going to close it out.
Okay.
Let's share the results.
And it looks like most of you thought it was 19.6 or 19,600. Okay. And then final question.
Right.
So how many adults aged 52 to 75 are currently past due for colorectal cancer screening? Nearly 15 million, nearly 18 million, nearly 23 million, or nearly 25 million?
All right, it looks like we're at about 55% have voted, so I'm going to close out.
Okay.
Share.
And let me see, nearly 25 million is got the most votes. Okay. All right, so let's take a look at where we're going to find all these answers. All right. So for the drop in colonoscopies by mid-April compared to the same time period in 2019, the answer is actually 90%. I think most of you voted for 70%, but it is actually 90% compared to the same time period. For the estimated delayed diagnosis of colorectal cancer screening, most of you answered 19,600. It's actually 18,800. So just a little bit less than your estimate, but still a very big number. We also have 1.7 million missed colonoscopies. And this is the one that's really kind of scary. So they're estimating an excess death of over 4,500 from colorectal cancer screening over the next decade as a result of these delayed diagnoses. So it's really a little bit scary. And for the last polling question, it's actually 23 million adults that are past due. So again, early in the pandemic, you can move on to the next slide. Early in the pandemic, CMS and the American Cancer Society had made recommendations to delay all non-urgent procedures. And this, along with, patient fear of coming in for visits, has led to this drop in screenings. And in fact, even with cancer patients, 40% of colorectal cancer patients and caregivers reported disruptions in their care. So, COVID has really had a big impact on, screening as well as, actual care of cancer patients. Next slide. So this kind of just shows you graphically how precipitously the colonoscopies fell. This is, I know it's a little hard to read, but this is from January through April. And you will see that just around mid-March, you see that drop. The blue line is 2019 and the purple is 2020. So you can see the big drop in colonoscopies. Just starting in mid-March, it just went down very fast. And the next slide shows you the drop in colorectal cancer diagnoses. Again, same time period, January through April, and the blue line is 2019 and the purple is 2020. So you see the diagnosis of colorectal cancer has also gone down. And you see it just starting in March. And again, that's because we're not doing those diagnostic tests. So this is something that really needs a lot of attention. And I know even in our data, we know that those screenings have gone down. I'm just looking at the data that I have year to date compared to last year, the same time, looking at HCN network wide for those centers that we get data for. We went from 45.5% compliance on colon cancer screening last year through July. This year, year to date through July, we're down to 40.1%. So we've seen it also in our own data. So the National Colorectal Cancer Roundtable has really kind of outlined 4 guiding principles in response to screening delays due to COVID. And the first one is that, basically, despite the challenges we face with the pandemic, colorectal cancer remains a public health priority. And therefore, we must really try and find safe opportunities for screening to help prevent and detect the colorectal polyps and cancers. The second one is that, although colonoscopies are safe and good options, and we have more and more sites opening up for colonoscopies, it is important now to really identify patients who should be given priority for colonoscopies. For example, those who test positive on a FIT, rather than just sending everybody for a colonoscopy. So we just have to try and send those that have a higher risk for colon cancer for colonoscopy. The third principle that they outlined is one that we actually use quite a bit in our centers, especially for those people that don't have insurance and can't get the colonoscopies, and these are safe at-home stool-based tests. And then the final principle is really kind of gaining the momentum for reigniting screening. We'll need a lot of public messaging, and this will be dependent on local requirements, public health priorities, and policy changes. So moving on now, looking at FIT testing, one of the things that they kind of went over in this webinar was this really increasing the use of mailed FIT testing as an ideal approach for maintaining screening during COVID. So, really simply reopening our facilities and offering screenings will not be enough to get patients in the door. Patients are still scared to come in. I know it depends on where you are and to what degree this is. I know some centers are getting in more patients, but there's still a lot of patients who are concerned and are not coming in. And of course, this then leads to, less FIT tests being done, less colonoscopies being done. So mailed fit tests can mitigate the impact of COVID. Doesn't require an in-person visit. Doesn't require for the invitation, nor for the distribution or the return or any reminders. And even if there's an abnormal fit test, the initial, arrangement for colonoscopy can be done remotely. Now, I know for some of us, the mailed tests may not always be an option, and I want to talk a little bit after I finish this about what you guys are doing, if anybody has any experience with using mailed fit tests. If so, is it both sending it out and receiving it, or having them mail it to the lab, or is it that they pick it up from your offices and then mail it back? So I want to hear about what you're doing, but definitely this was one option that was really being encouraged. Again, with telehealth visits, this actually can lend itself very well for the initial discussion with the patient. Of course, we'll have to think about now, how do we enable kit distribution? Again, are we going to have the mailed option overall, or can they come and pick it up maybe from a drive-through or some kind of other option? So these are things that we would need to consider. And again, I would love to hear if any of you are doing any of this. Next slide. So again, they outlined some best practices that they've seen across for mailed fit testing. And just to go over them, text, telephone calls, printed mailings before you mail out a fit test appear to contribute to effectiveness. These are things that they found in various studies. Invitation letters should be brief and easy to read, and they should be signed by whoever is most appropriate. I know in most cases, patients respond more to something that's signed by their own provider. The instructions for FIT should be complete, simple, and address any challenges that may lead to failed lab processing. Example, not noting their collection date and things like that. And then reminders should be used to address anybody who has not returned a fit test in the time that, in the time allocated. Next slide.
I do want to say Saul Bermudez has raised his hand. I'm going to mute your line so you can speak.
Is there
Saul,
a question?
are you there?
Yeah, sorry about that. I'm not sure how that got kicked, but no, I'm good. Thank you.
No problem.
Okay, not a problem. So again, the next one is that you should have data infrastructure that should identify eligible patients and track each step of the outreach process. So here, we have an advantage. We can easily identify those of our patients that are non-compliant for this measure. All we have to do is run our reports, get the details, and sort it by compliance, and there we have our list. So this is something that we should be easily able to do as far as getting a list of our patients that still have a care gap for this. And then we should really, if we are going to be mailing out fit tests or even just giving them out, we should have a process where we are tracking this and sending out reminders for those that have not been returned, and then, of course, following up on any abnormal fit. So again, high quality, one sample fit test is the best one to use. And in their studies, cost effectiveness of mailed fit tests has been established. So again, this might be something that you guys may have taken a look at to see is there anything that are the costs prohibitive, or is it something that you can do, or have you been able to get any grants that can cover it? So just want to go back one slide. Let's just spend a little time, a couple of minutes, if we can open the line. And any comments, anybody who's tried mailed fit testing or any other things that you've tried during the time of COVID to try and increase your colon cancer screening. I'd be really open to hearing if anybody would like to speak.
The lines are unmuted, so anyone can unmute themselves if they're self-muted.
Hirut, how are you?
Good. How are you?
Good, good. I'm glad that everybody's fine.
Yes, indeed.
Hirut, so basically, we have tried in the past, and
Mhm.
we have tried to retake the same practice of mailing out fit kits. So two things that we've learned from our experience is that the there is a little bit of a burden that you have to put into the staff because you have to track the amount of test kits you're sending out. You have to make sure that you are sending reminders on a weekly basis to the patients. And then the mail back is sometimes complicated. We've noticed that usually you have to almost double the amount of test kits being sent out because either they don't know how to take properly the sample or they damage the sample. Or second, we noticed in certain instances that when they send it back, we never got it back when it was mailed back. I don't know. We had patients complaining that they had sent it out through the mail and it never arrived. So that's been our experience with it. It's a good idea, but it requires extra detail in terms of tracking who got it, who was mailed out, send out the reminders, and obviously even though now all the fits are very, they have a simple step to follow. You still have the need to properly educate the patient. So those are the things that sometimes hinders the mail out, but it's a good possibility. I wouldn't go with what an insurance company did like 2 years ago. That is part of the Colorectal Cancer Coalition. They just basically send out fit test kits to the patients without even notifying the patient that something was going to be on the mail. They never educated properly the patients. So then it's a waste of money. So those are the things that we learned from it.
Okay, great. Yeah, and that last point was actually, I think, the first point that they made, that before you mail it out to them, you need to actually precede that with communication with the patient, that they're going to get it and what it is, and simple instructions. So, okay. Thanks for sharing that, Diego. Anybody else?
We have a few comments on the chat. Dr. Caitlin Hagardi said that they are about to launch and mail out the fecal occult test cards, and she will report back to us about their experience.
Oh, great. Wonderful. All right, would love to hear that. Maybe you can hear that next time. So again, just the main point is that we really need to think outside the box and think of ways that we can try and mitigate this drop in screening, because of course the result is going to be, higher morbidity and higher mortality. So that's something that we need to think about. All right, I know we don't have a lot of time, so I'm going to move quickly to pediatric immunization compliance. And this first slide really basically goes over everything that I've said to you in the past about pediatric immunization, making sure that your vaccines are entered correctly, making sure that you check your non-compliant patients, make sure that all the data entry is correct, checking your state registry, reaching out to patients that still have a possibility of becoming compliant, and again, targeting your 1-year-olds, especially for the flu vaccine. And that's what I really want to concentrate on today is, flu vaccine season is coming up. It is now even more important that we get patients their flu vaccine, and really flu vaccine not just for pediatric patients, but for all patients, but specifically for your high-risk patients, your diabetic patients, HIV patients. Again, with the complication of COVID, you really want to make sure that you get your patients vaccinated for flu. So looking at the next slide, we are facing the same problem. We have additional considerations in the time of COVID. So just our regular, push to get them in is not enough. We need to address patient reluctance to actually come into the clinic for immunization. And safe options for immunization visits need to be considered. And I know some of you are doing some of these things, and would like to hear what you're doing, but some of you have set certain sites as pediatric only sites. Some of you have blocks of time that you've set aside as just pediatric appointments, whether it's the certain days of the week or certain times of the day. Outdoor setup for pediatric immunization, now for, back to school, for those of you who are opening schools. Is there such options that have been done, any drive-throughs? So these are things that we need to consider, and I'd love to hear your thoughts on what you're doing. And definitely, we need to do aggressive outreach. We can't just expect them to come in. So, and again, that needs clear messaging, including availability of safe options and outlining those options, and then using all our communication tools to get this message out to our patients, whether it's a portal, text, phone, mail, all these different options. So I just want to spend like 2 minutes to hear from you. Anything that you're doing special for pediatric immunization, and especially in preparing for the upcoming flu season. If you could unmute the lines, and let's just hear from people just for a couple minutes.
The lines are unmuted.
Okay. Anybody who's doing anything special that they would like to share? Okay, doesn't look like we have any takers. I do want to point out, I am pleasantly surprised that as far as overall pediatric immunization, year to date, comparing last year to this year, we're actually kind of at the same place. So, really very happy with that, and I just hope that we can keep up the momentum the rest of the year as more of our patients come in, that we are really keeping up with the immunizations, and hopefully we actually have a chance to exceed last year's compliance. And the last one I want to talk about just for a second is diabetes poor control. Poor control is going up. Checking our numbers year to date for those centers that I do have access to data, our poor control year to date through end of July 2019 was 29.9%, and this year it has gone up to 38.5%. As you know, this is a measure that we want to see the number going down. And then just taking a look at some of your data and looking at what's, we can see clearly that missing HbA1cs are a major contributor, and this is no surprise. And again, it's the same thing that we spoke about with pediatric immunization and any other in-office visit. People are reluctant to come in, so we do need to have some safe options. I know we've in the past talked about drive-up testing. People who have time blocks for lab-only visits. Calling in patients one at a time into the lab, having patients waiting in the car until it's their turn, things like that. So these are things that we really need to ramp up right now, because our diabetes is again another major public health concern, and we need to put some more effort into really trying to see how we can mitigate the drop in compliance or the poor control that is going up, and again primarily driven by missing HbA1c tests. So again, clear messaging, patient engagement with clear messaging, safe options for testing, and using all our communication. So again, anything that you have on this, I would love to hear. And after that, we can move on to our two centers that are going to be presenting on some of their practices around some of these measures that we just talked about. So I think maybe we'll let them go first, and then hold your thoughts on this one. And then since they are on the same subject, and then we can open up the lines after.
Right.
These here, yeah, these are just provided for you to look at. I'm not going to go over them right now. I did provide in the deck that you're going to get the year-to-date 2019, year-to-date through July 2020 UDS compliance for all of the centers that are giving me data.
Thank you, Harut. We're going to move on to the Health Center Spotlight. We do have Dr. Sal and Dr. Gates presenting from Providence. Dr. Gates, Dr. Sal, are you with us?
Hopefully, can you hear me?
We sure are.
Yes, we can hear you.
Okay. I'm trying to do this with a phone and also the computer. Can you hear me this way?
You might want to mute your computer so you don't get that double lag, but other than that, you should be good.
Okay, next slide, please. Hi, I'm Andrew Saul. I'm an MD, MPH, but proud to say I'm from a family of nurses, and this most distinctly will inform you on how I approach pediatric immunization here. I did give this talk a couple years ago to the CMO group at HCN, and 1 or 2 people sat up and said, yes, this is good, but the rest were physicians, and well, you know how we are. I've always loved QTECH because that's where the RNs and the informaticists live. So next slide. I did send a cheat sheet to Diana Chavez, and she can forward that later. It basically is a crosswalk of all of the CPT and CVX codes for the hot 100 vaccines we use here in the United States. And hopefully the informaticists on here, the second I say CVX, you know that if that's not right in the substructure of the universe of Greenway, the vaccine data won't flow right. So please, it's a nice cheat sheet, take a look at it. So if you're going to immunize kids, you have to realize that we, the physicians, hey, we can't help but get in the way. We do know how vaccines work, but we really don't have much of a clue about how to get them out and distribute them. And for that, we thank our nurses and our public health advocates. Next slide. So of course, take a look at who's in your clinic and say, who's really on my immunization team? Because I, the family physician, can indeed accidentally block vaccines if I wait to deliver it myself. Next slide. So we chose a nurse-driven process. And of course, we use standing orders to do all of our pediatric and adult immunizations. Basically, you know what I want for that child to have at 2 months, 4 months, 6 months. I only want to be bothered if it's an exception. Are they delinquent? On the adult side of the same equation, if you see COPD or asthma, you know I'm going to want a flu shot, and you know I'm going to want a Pneumovax. Don't wait to talk to me. So our docs helped develop these standing orders, and then we turned around to our team nurses. And of course, our job is to lead by example by trusting those nurses. And the balloon caption didn't print well here, but the underlying premise of this public health exercise is this. If you wait for me to click a button in the EHR to order the flu shot or the child's vaccines, then I myself have become the barrier to care. Next slide. And you can see here in 2015, under the old definition, we were flirting with 88, 89%. The new definition went into play in 2016, and that's the whippersnapper that now includes 24 moving parts before a child's second birthday, including 2 flu vaccines. And this thing just absolutely pummeled everybody across the United States. But we went and looked at our data and realized it was actually the second dose of flu was the most common reason people were failing this at the age of 2. And you can see that over a couple years, refining those standing orders, we recovered a full 10%. And now we are doing pretty well. Of course, we want 99, but we're happy to be right there at 72 at the moment. So remember that the second dose of flu is why most people were failing in some of these practices. Next slide. So there was our answer to that problem. If you wait for the second dose of flu to occur the next flu season, you're going to fail the test almost every time. But if everybody is giving that flu vaccine, you should have a nurse standing order that basically says, if I give flu vaccine number 1, bring the kid back in 4 weeks to give flu dose number 2. So that's one of the most profound standing orders you can create. Authorize your nurses. If I give flu 1, you give flu 2 4 weeks later. And that's a really quick and easy way that you can get 5 or 10 extra points on your immunization, assuming that your only problem is that second flu dose. The other philosophy we have is with our own pediatricians and family docs. And we've run into this repeatedly on med staff meetings, and we have these wonderful existential discussions about what's more important, to get the well child check or to vaccinate. And the answer to this, of course, is neither. The answer is both. They're both equally important. So if you run into people who are like, I must do the well child check in order to vaccinate the child, that's a problem. And it's a problem because if at best you might get 70% of the kids in to get a flu shot, you're never going to get your vaccine rate that high because the barrier to care is now the well child check. You don't discredit them. Of course, well child checks are important. But I think what we've proven here is even if I go out of my way to vaccinate the kids and then appoint for well child checks, we end up with about 70% well child checks, but we also get our vaccine rate up. So be ready to tackle that when you work with your docs. I mean, a lot of people are having this rather existential crisis about what it means to be a pediatrician in the age of COVID. If you can't see the kids, you run into problems. So go ahead and hit return on this slide. Looking for the barriers to care. Be aware that if you mandate a well child check to get the vaccine, you might want to look at that. And the other way is think about your patient-centered medical home diagnosis. If a kid's missing a vaccine, do you wait until it's convenient for the doc to see them? I mean, after all, we build a physician-centered medical home, right? Isn't that what the P is for in PCMH? Or is it about the patient? It is the patient, of course. So remember that the best of intentions in your policies and standing orders can cause harm. So take an objective look at them. Next slide. So here is one of the things we started doing. It's learn how to run a panel level quality report. And if you're inside Greenway or Intergy, we've spent a long time with this. Use the assigned provider field, not the PCP field. It's much cleaner and easier to do. Next slide. And this is what it looks like. And in our case, you have to recognize, and in your case, if you're running the PA report about children who are failing the vaccine, what you're really asking is, on the child's second birthday, who has already failed? If you really want to get ahead of this, you have to ask, who hasn't turned 2 yet? And if you hit the next return on this slide, there's a column there. There it is. We're actually running that data and giving the care teams the countdown. This child has turned 20 months old. This child has turned 21, 22, 23 months old. And so we're notifying each care team about which children are approaching age 2. And that allows the nurse to open up the chart, look at the table, and see if the child needs anything. So again, it's a very activated care team that's chasing the children with standing orders to immunize before they turn 2. Next slide. So of course, we're using panel level data to highlight success. We always talk about best practices, and we do encourage a little friendly competition. And you know what, we tied it to our incentive plan as well. Next slide. So we put this up in the break rooms, and hell hath no fury as a pediatrician scorned because a family physician is out vaccinating them. We do post quality data, and I encourage you to do the same, and please tie it to the incentive plan and make certain that the nurses and healthcare assistants are part of that, because they are huge pieces of this effort to vaccinate children. Next slide. And of course, the part you've been waiting for, the secret of success is all of the above plus a little common sense data handling. And this, of course, is our metaphor for the child approaching the age of 2. If you're running canned reports out of practice analytics, you only know who's crossed the finish line and already failed. You've got to take that technology and look at who's approaching the age of 2. And I'm going to wrap up quickly by saying, how did we vaccinate during the era of COVID? And our secret was kind of this. There were 2 groups of people that we knew, even at the height of the total lockdown, that we wanted to get in the doors of the clinic. They were, of course, pregnant women, and that other big group from the beginning was children under the age of 4 who needed vaccines, particularly the primary series through age 2. We're finding a way to get them into the building regardless. Now, we did screen them for flu, and if they had ILI or symptoms, we were switching them to phone. But if any child at age 2, 4, 6, 9, 12, 15 months needing a vaccine was deferred, the care team was very, very responsible, and we're watching very closely and getting them back in. And now, of course, is how do we plan to immunize for flu during the era of COVID? Well, our incident command team is now wrestling with the idea of how to deliver 30,000 vaccines over the course of 2 to 3 months. And we know that the dry run we use here, this framework we're building, is likely the same framework we're going to use when we vaccinate for COVID in the spring, God willing, and the river don't rise. But as we're tackling flu, we're looking at it through a different light, either in the building or out of the building. Vaccinating in the building, of course, is somebody who survived triage and got an appointment and got in. Hey, that's great. Never miss an opportunity to vaccinate them. But you can also do things off hours. So we have a couple mornings where we've got specialty clinics, and we're just going to turn those into nurse clinics and go vaccinate. Also Saturday. A lot of people are going to come in on Saturdays, work a little overtime, and just do flu clinics. Our out of the building strategies, of course, we're looking at parking lot tents. Now, you may not need the full COVID test to do this, but even a 10 by 10 foot tent in the parking lot with a nurse or two means that you can schedule your kids and they can come get immunized outdoors, try and keep them out of the weather, but that way they don't have to go through the whole rigmarole of being triaged and coming into the building by all the enhanced screening. The other great big strategy we're toying with is our COVID test site. We're looking at that now. We get most of our work done in the morning when we test patients, but in the afternoon, that same infrastructure is sitting idle. We are probably going to ramp that thing up into a drive-through flu vaccine clinic. And if this works well, we hope to knock out 30,000 flu vaccines in the next couple months and maybe 50 or 60,000 COVID tests in the spring. With that, I'm going to turn over to Dr. Gates. Take it away.
Oh, thank you very much. Complementary to Dr. Saul's care teams initiatives, I actually manage our accountable care division, if you will, and we're looking for patients who've fallen through some of those cracks that they just didn't get a chance to see their providers. We're running somewhere between 40 and 60% capacity, and we don't see that ability to see people in person changing in the absence of a tent. Next slide, please. So what we've been doing is identifying some measures that have been suffering, and no surprise to you all, colorectal cancer is one of those. We saw the rate of improvement it actually declined in our Medicare population. It was flat in our Medicaid. Same thing essentially is happening with breast cancer screening. So our hope was to offload the primary care team's time burdens and do some centralized outreach on those measures. And I'll preface this by saying a good 12 or 13 years ago, I saw a presentation by an accountable care organization in Hawaii, and they did something very similar to this, where they were using medical assistants to do the outreach. They spend half a day at each clinic. I'm calling from Dr. X's office. We'd like to arrange this, that, and the other thing for you. And they were able to really max out their colorectal cancer screening performance. And they actually got to the point where they couldn't book enough, there weren't enough mammogram machine slots available to book all of their people. So they maxed out the capacity. But as Dr. Saul mentioned, we got standing orders. We hired a licensed practical nurse who also speaks Spanish, which has been invaluable. We have some interns who are helping with our English-speaking patients. This outreach is managed centrally. We look for people with gaps who also do not have an appointment coming up in the next couple of weeks. We really didn't want to interfere with something that was probably going to get managed by the primary care team. So we were looking for people who, again, had a gap and did not have an upcoming appointment. It didn't really matter whether they had a recent appointment or not, but we did look for orders. We partnered up with one of our local labs to get fit tests and developed a process whereby we first text a batch of patients who have a known care gap saying, and the language actually turns out to be kind of important. We want to say something fairly definitive, like, your doctor recommends you get screened for colorectal cancer. May we call you? Or we would like to call you. Is that okay? And then we called every patient who replied yes to that texting platform, or if they didn't reply, because we find when they don't reply, It's not the same as a no, where you can convert a lot of those folks who don't reply to the text to yeses on the phone. If they agreed we're ordering a mammogram or a fit test, we also did a pilot with this in diabetic eye in the fall. We'll be doing diabetic eye very soon as well on all of these. And booking that patient for either a mammogram, a diabetic eye appointment, retinopathy screening, or sending them that fit test in the mail. What we're doing during that call, if you go to the next slide, is we're educating the patient on what the test options are between the colorectal cancer screening. We're recommending fit tests because we did the math on it, and not only are they a lot less expensive, but the rate of return, the rate of completion of them tends to be noticeably higher than that of colonoscopies. Somewhere around half of colonoscopies orders actually get performed. So we sent texts out to about 1,500 patients with a care gap starting in June of this year. We got a net of 254 fit tests sent out so far. 58 have been completed. As one of the other folks mentioned earlier, we do have an entire process whereby we're running an open orders report, and because all of our orders were entered by the same person, we just do the filter on that person. And we did actually find 8 positive fit tests in those 58 people, and one colonoscopy did reveal a precancerous polyp that was removed. So, there's no question that doing this is going to save some people from delayed or diagnosis or serious metastatic cancer. We did have 56 tests that had to be reordered, and that was the other observation, was that a lot of people do kind of improper specimen collection, or maybe some of those people who said yes didn't really want to do the test, and there were 32 that kind of got lost in the mail, so to speak. And we're just calling those folks back. We're trying to arrange it. We give it a few tries, and if the patient essentially doesn't want to engage with this kind of care delivery, then we're passing it back to the primary care team. Breast cancer over the course of 2019, we just ramped it up again in 2020, 250 patients. We were able to order 66 mammograms, 26 of them scheduled, and 17 were completed. And this is where it's important. If we go to one last slide, it's important to have a good relationship with your diagnostic imaging center and make sure they can get in. So key takeaways for this centralization process: it is a very low cost. You are relieving some of the time pressure and the visit pressure, if you will, under COVID terms for the primary care teams. There's absolutely a high return on investment against your quality incentives if you can get these up and you have quality incentives. Patients, there are definitely patients out there willing to engage in this kind of a process, but it certainly doesn't replace your primary care team and the standing orders and enabling your nurses to be part of that team of delivery. A few caveats: some of the breast cancer screening, some of the mammogram patients didn't want to shift. A piece of this was us trying to shift to facility testing locations, which tend to charge a lot less for the same service and even have the same radiologists in our case. And for the CRC, as I mentioned, despite education in multiple different ways, including low literacy flyer in the mailing, we did have a number of them that came back improperly collected, and we're just recontacting those patients, re-educating, and sending them another kit. And that's all I was going to say today, unless there are some questions.
Thank you, Dr. Sal. Thank you, Dr. Gates. I'm going to look really quick. I didn't have an opportunity to look to see if there was any questions in the chat.
I don't see any questions at this time.
Okay,
The other
good. Thank
thing
you.
I'll mention is that we are in the process of creating a standard form and Entergy for tracking multiple centralized quality outreaches. And once we get the bugs worked out, we certainly don't want to patent it. Happy to share. It'll enable you to do reports on what stage of things like a fit test is in, that kind of thing.
All right, thank you. Well, I actually was looking at the time and we're at 4:27. We did have one more health center speaker on, but I think due to the time. Robin, if you don't mind, could we bump you to next month's meeting? Would that be all right?
Sure, that would be okay.
Thank you so much for understanding. We'll definitely have you at the top of our agenda. So her slides are in the deck for those of you that pulled them down from the panel bar, but she will have Robin present at next month's meeting. So other than that, I did want to show you some quick, before we let everybody go, some quick updates. I wanted to see, can you see my screen all right? Let's see. Yeah, okay. We do have our optimization telehealth work group. It's still going on. It occurs every fourth Tuesday of the month from 3 to 4. If you're interested, please contact us at HCN Quality Programs. We'd be more than happy to take more folks on. We also have our Project Echo Diabetes information session coming up on Tuesday, the September 8th. It's from 12 to 1. You can register for that as well if you all are interested. We have our clinical leaders workshop coming up. It's for our medical directors, clinical leaders, CMOs. If you know anyone who might be interested in this, it is happening on September 9th from 12 to 5 p.m. Eastern Standard Time, and it is virtual. This is a new format we're trying out, since normally this is a 3-day workshop and it is in person at HCN. We're going to try to break it up virtually since we can't all be together. And then we also have our cybersecurity sessions going on. We had our first one today, actually, at I think it started at 12, if I'm not mistaken. But we do have sessions 2, 3, 4, 5, and 6 going on. If you've got IT folks who are interested in this, it's all around cybersecurity. This is a joint PTECH and QTECH collaborative that we are doing with our sister network, the Alliance Chicago. So it does fall under the goals that we are doing for the QTECH grant. And then we do have finally our session 12, I think, of our COVID webinar. It's going to be on COVID testing and mitigating the flu during flu season. So register if you get a chance. Do we have any other slides coming up, Diana? Oh, we do have some dates to remember on there for you all. You can look through those. And of course, our resource libraries up on the HCN website. And we also tacked on some NAC resources for you all as well. And that's pretty much it. Just save the date. We do have our Alliance Chicago and HCN virtual conference open to all, free for all. It's going to be held November 4th through the 12th. Registration is actually going to open up in the coming week. So save the date. More information will be coming on that. And I think that's it. We are at the 4:30 mark. Thank you all for attending.
One quick thing. Be on the lookout for poster presentation opportunity for this virtual conference. We would love to have some of you present a poster. It's going to be a virtual poster for the conference. So please be on the lookout for that communication. Get your ideas together for a poster session. Thank you.
That's it then. That's it for me. Thank you all for attending. We'll see you all next month, September 24th. And we look forward to having you all back on to listen to Robin speak on her Health Center Spotlight. Thank you. Bye.
Thank you, everyone.
Thank you. Bye-bye.